I have the great opportunity to introduce you Professor Ewa Ageberg from Sweden. She's a leading researcher in sports injury prevention. She has published over 90 peer-reviewed papers, and Ewa's work develops evidence-based strategies to protect and improve athlete health. And yeah, let's warmly welcome.
Thank you very much for that nice introduction, and thank you so much for inviting me to this conference. Mario, this is a fabulous program you have put together, you and your team. I have learned a lot, and I hope that you have too. I think you have, and I hope you will stay awake for these last 30 minutes, where I will talk about motor imagery to facilitate sensory motor relearning. So we know that although patients have rehab, and we do a good job as physios, they still report worse outcomes. They have persistent sensory motor deficiency. And it's important that we do improve physical function because it's related to return to sport. But we have also heard today, and you probably know that from before, that there are a lot of athletes that do not return to their previous sport or to activity. So what can we do to optimize treatment? And can we do it? And if so, how? So if we look at the evidence-based recommendations, I'm sure you are well aware of these. Focus is on restoring physical function. So with structured, individualized, and progressive neuromuscular and strength training to improve function. It is also stated in these recommendations that we should focus on psychological factors. We have heard that today as well. But there is not much out there, and there are no structured programs how to integrate that within the physical therapy programs. There is also a recent study, the ACL-RSI is usually used, but it's not really fully, doesn't really fully recover return to sport. So there is a need for research on interventions to improve psychological readiness to return to sport, not just physical readiness. But why are psychological factors important? We have heard some about it today. We know that higher self-efficacy, reduced fear of re-injury, greater satisfaction with knee function, self-determined motivation, external focus of attention are associated with better knee function, higher likelihood of return to physical activity in sports, greater compliance to training, more natural movements and increased activity-relevant brain activity, and increased readaptations to real-world situations. So there is something there. So based on current knowledge, evidence-based recommendations, and patients' experiences when it comes to both physical and psychological issues with rehab, we asked ourselves, if we were to integrate psychological factors in current rehab, can we increase motivation, enjoyment, and patient ownership? And can we improve self-reported and objective outcomes? So we established a team, interdisciplinary team of researchers and clinicians with expertise in sport and exercise medicine, sport and exercise psychology, and clinical physical therapists. A great team, but it takes time to find a common language when you merge people and integrate. We call the model motor imagery to facilitate sensory motor relearning, or MOTIFs, and the popular science title is Train the Brain. And in contrast to having separate interventions, the MOTIFs model has a uniquely holistic approach based on an integration of individualized physical and psychological training methods for rehabilitation of real-world skills. So to influence psychological aspects, we integrate psychological skills training, which is a set of tools aimed at improving performance, enjoyment, satisfaction, for example, And this type of training can include aspects like goal setting, self-talk, and arousal regulation. We decided in our project to focus on imagery, specifically dynamic motor imagery, and that is when a participant images a specific situation while simultaneously physically mimicking part or all of the movement, and in order to increase realism. So not lying on the sofa, imaging the movement. So we developed a new model in which realistic sports situations are integrated into physical exercises. It's done in 4 steps, and Suzanne touched about that in her talk. You discuss with the patient, that's an important part. You design the exercise together with the patient. You execute, evaluate, and then continue. So this is an example of a rehab exercise, a toe off. The physio has decided this person needs to improve her toe off. But we wanted to do it more realistic. This is a soccer player, so the therapist asked, okay, when in your sport did you do this? And she says, well, when I had the ball, and she's not at the point where she could do the jump, but just the toe off. So as you see, she heads the ball, she still does the toe off. We have a screen, this is very simple, you don't have to do it complicated, of a goal on the wall. And she executes the exercise. She focuses on heading the ball, whereas the physical therapist focuses on the quality of movement because we don't want to decrease that. And then you could add more components. Let's say, where in the goal do you want to head the ball? Make it even more realistic. Let's say it's the last minute of the game. If you score this goal, you will win the competition. And I think you can see the other movements of her body as well, not just doing the toe off, because that's how we move in the real situation. And then you can add even more, like what happens on the field after you have the ball. You keep running, but she could maybe walk instead. She could really, cheer, be very happy about the goal. So making it as realistic as possible. First, we wanted to find out, is it fun and meaningful, or was it just us that found it fun and meaningful? So we did a crossover experimental RCT, and our hypotheses were confirmed. The participants perceived that motifs was more enjoyable. They found it more positive, they were more active, they were more in control. And these are psychological measures. Perceived exertion and heart rate were higher. And movement quality was maintained, and that was important. So our conclusion from this first study was that motifs is a plausible model to influence patient-reported outcomes by integrating psychological and physical training principles. But what did the physical therapists and patients think about the model? So we did 2 qualitative interview studies, one with physios and one with patients. If we start with the physical therapists, they perceived that motifs increased psychological focus during the rehabilitation training. It was clear, and they had concrete advice and tools during rehab. And they also perceived it as a structured method of addressing psychological factors, such as using imagery to influence patients' motivation, fear, and preparation for return to activity. When it came to the care as usual training, they said that was mainly focused on physical and lacked the necessary psychological components. So the conclusion from this study was that physical therapists perceive motifs training as a method of shifting the rehabilitation paradigm towards a conscious and directed focus on simultaneously addressing psychological and physical factors. What about the patients? The results from that study indicate that patients in the motifs group perceived individualized meaning and sport relevance in their rehab training, and that imagery was perceived to be a concrete strategy that can be difficult. Some found it easier, some found it more difficult, but it encourages a biopsychosocial interaction to improve confidence, motivation, enjoyment, and sport-relevant context. So they did perceive the rehab as both physical and psychological preparation for return to activity, using structured and explicit strategies which aid in coping with negative psychological factors. Does it work? Joanna touched upon this in her talk. This is a new model, so what we did was that we conducted an adaptive RCT, including patients with traumatic knee injury, to test this. And given that it's a new model, we decided to do an interim analysis, and that is when you stop halfway through and do the analysis and see whether you should continue or not continue or do any modifications. So we included people 16 years and older with traumatic knee injury. They were already doing rehab for their injury. They were randomized to either motifs or care as usual, and baseline was when they had started single leg hop in their rehab. They trained for 12 weeks, the same training in both groups, and the motifs, they added about 20 minutes of the standard 60-minute session with motifs exercises. Because you do need to use your brain a lot, so you can't do it for 60 minutes, that's too much. So approximately 20 minutes. And then we had some continuation criteria, and when we started this study, we figured, okay, let's go for those outcomes that are out there. So we had ACL return to sport after injury scale, ACL RSI, side hop limb symmetry index. It's more demanding than the one leg hop for distance, and change in enjoyment. But as you heard when Joanna had her talk, these criteria were not met. There were no differences between the groups in this interim analysis. And that indicates that we need to do major modifications to continue this trial. But given that the patients and the physios, they found that this model was meaningful, it was helpful, it actually helped them to prepare for return to activity, we think that we need to move on and look for other outcomes that are more relevant to actually capture what we want to do and with this type of intervention. And that could be meaning and motivation. I think that's very important. And also neurocognitive challenge tests, which I know that Dustin does a lot. So something along those lines. We'll see where we end up. But we also wanted to do, I think Joanna touched upon that, in Sweden, there are sports psychologists for elite athletes, but other than that, you don't have them in the clinics. So the sports psychologists need to train the physical therapists to do these types of interventions. So what we did now, we brought in some new people from Norway and Denmark, and we did a survey study among physical therapists in Sweden, Denmark, and Norway. And we asked about whether they use psychological skills training in their rehab for people with knee injury. And what we found, this is just one of the data points that we have, and this is a paper that you will be able to read quite soon. It's accepted in the theme issue of International Journal of Sports Physical Therapy. They used goal setting. All of them did that. That makes sense, I think. But only about half of the physios used imagery and arousal regulation. And the reason for that was that they didn't have the knowledge. They didn't know how to do it. So given what is recommended, there is an apparent underuse of psychological skills training. And what they wanted was education and workshops for strategies to increase their knowledge. So that is something that we from the research field can work on, I think. But is it brain training? We're talking about train the brain and motives. And this is tricky. So again, some new people in, new expertise. And we are using fMRI. And for me as a physio, I was like, oh yeah, that's fine. That's going to be possible to do, but it takes a lot of planning, a lot of piloting to do. You also need the participants to familiarize with the equipment and the testing. And if you're with Dustin in Ohio, you have this really cool mock-up. It looks just like an fMRI. I've tried it. We don't have that in Sweden. So we did our own. A box with the fMRI camera on it. But it does actually work. So this is a mock-up. I'm going to show you what they do. Because what we wanted to do was, Dustin showed a knee extension, but we wanted to test the motifs. And the motifs is, as you've seen, it's both the physical and the psychological, making it as realistic as possible. A lot of piloting. So in this, and they built this device themselves, Simon and Nicholas. Isn't it cute? But in the camera, now they do actually have 90 degrees of knee flexion or hip flexion. Otherwise, it doesn't work, because you have to make sure that the head is as still as possible. So what we do in this trial, this is ongoing, and Dustin is on board. We have 3 conditions. So we have a movement-only condition, which would simulate a carrier's usual exercise. We have visual imagery, so just watching a video, you will see this shortly. And that would be like, as I said, lying on the sofa imaging movement. And then we have movement plus the visual imagery, which simulates the motifs. So with the visual, we have made this video. So they are watching this, and in the motifs, they are asked to put themselves in this situation. Imagine that you are that player kicking the ball. So in the exercise, in that condition, they actually follow exactly. So they hit the ball that is hanging there during the fMRI scanning. This is ongoing, so I don't have much data. I have one brain to show, and that's my son's. So if we look at this, and again, it's just one participant, we're going to have 15 in this trial. For the movement only, so it's just a countdown, 3, 2, 1, kick, 3, 2, 1, kick, and that's what they see on the screen. These are the areas that are activated, so the motor areas in the brain. If the person is just watching the girl hitting the ball, the visual areas of the brain are activated, so the green areas here, and no activation in the motor areas. Whereas in the movement and visual, so the motifs exercise, where they kick the ball and watch the video, there is activation in both areas, both the visual and motor areas. And here's a picture with the overlap. So the red is the movement only, green visual imagery only, and blue. And that becomes purple because red and blue on top. That's the movement and visual imagery. So the preliminary interpretation so far with this participant and a few other subjects, the motifs exercise largely overlaps with movement only and visual imagery only. So we'll see where we end up with that trial. The first trial is to make sure that it works. If it doesn't work, we have to reconsider again. And the next step will be to do the same trial with patients with knee injury and see how their activation is, and also with a short-term motifs intervention to see if we actually do affect and do train the brain. So stay tuned on that. What else? What about the body? You saw that toe off with just sort of the toe off, nothing else. And when she was heading the ball, there were a lot of other movements going on in the body like it does in the real world. So we also want to find out if there are any biomechanical differences. These are also ongoing studies. I only have videos to show you, no data at this point. But I just wanted to give you a sort of an idea what we are doing. So we brought in an expert in biomechanics And this trial, what we're doing now is we have handball players. They are doing cutting movement. Let's say that would be end stage of the rehab. They do it as a care as usual, where focus is on, this is the first video, where the instructions are focus on how you land, you know, those typical things that Anna Benjamins brought up too. And then they have the motives instructions, where they are asked to, while they do this cutoff, simulate a realistic handball scenario according to these principles. They don't throw the ball, but they still are asked to do that. And this is what that looks like. So the person here was asked to simulate a shot and was also instructed that this is the last minute of the game and you're one down. So all those aspects to increase realism. And then we're going to look at biomechanical factors that are known, for example, risk factors for knee injury and automaticity in the movements as well. As I said, this is a model, and for me it's really important that we develop models that can be applied to different groups of people, not certain exercises. So this is also a study that we recently started, where we apply this to patients with OA, knee OA. So again, brought in some new people with expertise in physical therapy and clinical biomechanics. They are not doing that cutting movement. We have other common tests for people at that age. The time up and go test, for example, and they do the stair, just stair ascend and descend. So the thing here is also to just give the instructions, and now I'm going to show this is a healthy participant, so you don't see any effects of a knee OA in this participant. But this is the timed up and go test. So the first trial here is the instructions that are out there. So they tell, okay, you should stand up, go 3 meters, turn around, and go back and sit down. In the next, with the motives, the sport physical or the sports psychologist discussed with that person and said, okay, picture you in daily life. When in a situation during daily life would you do something like that? This was me, actually. So I said, well, I would sit down and then realize, oh, I forgot my glasses on the desk. So I got up and I, as you can see, reached for my glasses and then went to sit down again. And also in this trial, we're going to look at different biomechanical factors and variables again. And also like step length, symmetry, smoothness, fluidity in this trial. And we don't say this is exploratory, so don't say this is good and this is bad. It could be, for example, that you could see that I did it a lot faster when I had a task to do, whereas if I was only given those instructions to just go up and turn around and go back. It could be that it's a higher speed, but maybe more happens in the body. Whether that is good or bad, we don't know. But we just want to see what happens with these instructions. So to the practical implications of this model, as far as we have come right now. The motives model with integrated psychological strategies to create more holistic rehabilitation can be used by practitioners through individualized discussions to simultaneously, physically and psychologically simulate individually relevant scenarios involving the person in decision making and exercise design. And I think that is really important. It may be beneficial to improve patient-reported outcomes, at least when it comes to motivation and meaningfulness and enjoyment, and those are factors that are important. Rehab can be boring. Patient readiness to return to activity can benefit from this intervention. And physical therapists perceive the model as a method of consciously shifting perspective toward an increased focus on psychological factors in rehab. And they request education to gain knowledge on psychological skills training. So we have some work to do there, I think. And we're at the point now, which outcomes are most appropriate to evaluate holistic and complex nature of return to activity? Thank you very much to all the collaborators and funding sources, and thank you for listening.
Thank you, Ewa, for your presentation. Are there some questions? Don't be shy. No.
Thank you.
Here,
Are there any other reasons instead of popularity why you choose soccer instead of, for example, swimming on the back for the fMRI?
You have to do an exercise that is possible to do in an fMRI camera. And a leg movement you can do. You can do finger movements, but other than that, it's really complicated because you have to have your head very, very still. Otherwise, there will be a lot of artifacts in your data, and you can't interpret what is what. So we had
the leg movement of swimming on the back.
Oh yeah, you could probably do that.
Because the pro is usually when you swim, you lie on the horizontal, and soccer, you have the body vertical.
Yeah, that's true. Because it's not, you never lie down and kick the ball. So yeah, that would be interesting to do, definitely.
So Jessica in the front.
It's a lovely talk. I'm just trying to think crossing over with concussion, just seeing some of the work that you're doing with the fMRI. And I'm wondering, just even looking at that 3D model that you had with the motifs, like the cut, you had so much more vertical displacement on the ladder. So I'm almost wondering if you could almost incorporate like a fear avoidance, with the motifs to potentially see if they're almost distracted from whatever they're recovering from, and to see if they, have, increased force, increased vertical displacement, or even return quicker. I'd just be curious to see. We see it with like cognophobia and also kinesiophobia with movement, fear of movement. But it'd be interesting to see if that would be incorporated in the future potentially for you.
Yeah, that's really interesting. I think that I talked to Joanna earlier today within the interview study. What the participants in the motives group said, the patients said that they were, through this model, it was more realistic, it was more meaningful, it helped them with psychological factors to return to activity, but they were more aware as well. So I think that it could be that those that are, like Joanna talked about, that they don't have enough fear, they have a really high risk behavior. Maybe that can help them to not, be a little more to the center of the curve. Yeah. That's possible. And I think also with the task, and they design it themselves, so hopefully they won't design an exercise that doesn't really work, and then you just evaluate and do it again. But it could be that you take focus off. You don't look at your knee, you focus on the task and the external focus of attention, and that probably helps too, I think, and makes it more realistic.
Yeah, I think even for us, like the contextualization and the saliency for concussion rehab, we have to take them away because they're just focusing on their symptom. So this is totally similar in terms of, so very cool, very, very well done.
You should try it on concussion and see.
So I think we have no more questions. So thank you very much, Ewa.
Thank you.
And yes, we are
Close
by the end. And Nico.
Yes, we are. We are at the end of this symposium stay. On behalf of our committee, I would like to thank all the speakers with their interesting presentation. Thank you very much. I want to thank you, participants, and we hope that you have been inspired and you bring home some useful knowledge and how the brain can sublimate our rehabilitation. If you want to see some presentations, they will be on our YouTube channel in 2 or 3 weeks. And for our members, in 15 minutes there is our general meeting. And for me, I want to remind that in 2025 there is a common symposium in Lausanne, and I hope that we see you at our World Conference in 2026 here in Bern, and probably in the new building. So, good home travel, stay in good health, and bye. See you next year.